Okay, this video is going to be called Thyroid Biopsy, How to Do a Thyroid Biopsy by me, Pete Rogers. So here's a normal looking thyroid right here. It's in the lower neck. Tracheal cartilage up here. There's a little bridge across called the isthmus, the right lobe of thyroid, left lobe of thyroid. 3 small nodules, probably too small to biopsy, less than a centimeter. This one's a big one. It's even higher risk if it's got calcifications in it, for example, if it's solid, hypoechoic on ultrasound. So this will be our biopsy, let's say. By the way, I've done about 1,000 of these. I'm pretty comfortable doing thyroid biopsies. The techs will ask me, we sometimes get a young junior tech. Do you want to review the films a day in advance? I'm like, nah, I'm like an old prostitute. I just do whatever's on the schedule. I don't even think about them anymore. If I can see it, I can hit it. This is a picture of me when I was in my 30s. I went through a fat phase when I was primarily a surgeon, imaging guided surgeon. I wrote a textbook of interventional radiology. This is the Spanish language version of it, the pocket radiologist for Amersis Elsevier, which is like the biggest radiology publishing company. There's me as a lead author on it. It's a pretty popular book back in its day. Okay. Now here's a typical looking thyroid nodule on ultrasound. I'll get myself out of the way here. It's the thyroid itself has intermediate echogenicity. This nodule's everything on ultrasound's echogenicity, how bright it is. So this is mildly hypoechoic solid nodule. A little bit of through transmission. It's hyperechoic distal to it. So the sound is going through this faster than it is through the thyroid. These are the adjacent muscles. So there will be our thyroid nodule for biopsy and ultrasound guidance. This is a little bit higher risk nodule. This one has a macro calcification. You see a big shadow behind it. Here's an even bigger calcification. Calcifications increase risk of malignancy. So these are, you measure a thyroid based on the size of the nodule and also based on its features, its morphology. So this would be a high risk nodule because it's got macro calcifications in it. So we'd be more likely to biopsy it even at a relatively smaller size. Before every procedure, you got to write a pre-procedure note. Here's a standard pre-procedure note. Planned procedure. Ultrasound guided biopsy thyroid. Indication, thyroid nodule meets criteria for biopsy. Who's the doctor? Me. Who's the referral? ENT, endocrine, something like that. Labs are okay. Allergies, none. Medicines reconciled. A lot of times we're holding in some anticoagulation like a Pixaban for atrial fibrillation times 48-hour hold. Okay. History of present illness as above. PMH, past medical history. 60-year-old woman, typical history, hypertension, diabetes, BMI 35. She's fat. That's going to make it harder. She's going to have a big fat neck. Coronary artery disease. They all have coronary artery disease. GERD, gastroesophageal reflux disease, the AFib like we talked about, that's why she was anticoagulated, hip replacement, Parkinson's disease. I don't like it if they got Parkinson's because sometimes they're moving a lot. They can't stop moving if they got Parkinson's or some other movement disorder. Tracheostomy. I don't like if they got a tracheostomy. They got a trachestoma here. They got to be real careful. I can't put saline. Saline is my contact. I can put gel, or I can be very careful with the saline. But it makes the case a lot harder. Plus, they start to inhale the prep into their trach site and they start coughing like crazy. COPDers are a little bit difficult too. If they're short of breath, they're on oxygen, because I can't put them as flat. Same thing with CHFers, congestive heart failure patients, because the saline will just run off when their head's elevated. I like them to have them flat supine. Okay, flat supine, not head up. When the head up prep drips off real fast, it's not so much the prep, it's the saline contact for the transducer. So I can also use gel in that case. But pathology doesn't like me using gel as a contact because it gets in the specimen and they're not happy about that. They whine about that. Here's the prep. This is typical chloro prep. It's orange like a pumpkin. I spin it around in a circle from the epicenter where I'm going to go into the lesion. And then if I have residents watching me, which I sometimes do during a case, I always ask them, where do you think I learned to prep like that? In prep school. Okay, Couple jokes. We always do a timeout before we, ready to puncture the skin. And, the patient just has to state their name, their social, do they understand what we're doing? We always do an informed consent, risk, benefits, and alternatives before every case. Pretty standard stuff. Okay, so now here is the biopsy needle. I like these often for my first needle pass, especially if it's a difficult nodule. So this needle has a stylet, 25 gauge, typical thyroid biopsy needle. The advantage of having a stylet in there is that it doesn't clot off. So sometimes I'm trying to figure out a complex angle. I got a real deep nodule, and if I got adequate visibility, I'll go into it with this styleted needle. Because again, with the stylet, I got time to figure out the angle, and the needle's not going to clot off. Okay. If there's no stylet, there's a trade-off. So here's a typical setup when there's no stylet. This is a hollow needle. Okay, the bevel is the cut edge of it. Lure lock connection to a syringe. Here's the stopper in the syringe, the thumb rest. Usually I use a 10 cc syringe. These needles, because they have air inside of them, there's no stylet, they're more hyperechoic under ultrasound. It's easier to see them. And if you got a clear path to the nodule, these are the best needles to use. But the problem is sometimes you don't. And if you don't have the angle figured out and you can get into it real fast, this will clot off on you. So you have to be able to get into the nodule real fast to use these. And don't get me wrong, this is what I use most of the time. But for figuring out, I a lot of times do really complicated cases, so I'll like that. In the old days, I would have to sometimes do core biopsies of thyroid. Nowadays, I almost never do a core biopsy of a thyroid. So the standard FNA, fine needle aspirate, that I just showed you are 25 gauge, which is really small. Imagine you could put 25 of them side to side to make an inch. It's almost about that size. The core biopsy needles are more like typically 18 gauge. 20 gauges usually don't work so well, but you can sometimes use a 20 gauge core. They got a little slot here, a step off. So the specimen they obtain is much bigger than an FNA. With an FNA, fine needle aspirate, the pathologists, cytologists, they're just looking at the individual cells. With a core biopsy, because they got a much bigger chunk of tissue, they can see the relationship of the cells to each other. That's called histology, because they're looking at the architecture, let's say, of the nodule, of the tumor. And the specimen looks about the size of an inchworm. Okay, so it takes out a bigger specimen, more likely to bleed. You need a bigger nodule in order to have the room for excursion of the needle to do a core biopsy. So again, I almost never do those in a thyroid anymore. I do core biopsies once in a while for things like lymphomas or other unusual tumors. Nowadays, pathology's gotten better and better. Almost everything can be done with FNAs, 25 gauge needles. Okay, here's a typical setup. Here would be the ultrasound probe. Here would be the needle. Usually I like it long access relative to the transducer. Okay, so transducer looks, I don't know if I got a good thing I can use here on my desk for a transducer. Let me see, I got something I can use with a transducer here. This would be the transducer, and I'll have my needle along its long axis. So the more of the needle I can see, the better. The easier it makes it to do the case. Okay, I'll show you some other examples of what that's like. Okay, here's what it looks like in real time. I'll be coming in from the side here. And here's what it looks like in the drawing. They have the transducer. Needle is orientated along the long axis of the transducer. So the needle's like this. And then here's the needle coming in. The needle's going to be hyperechoic, meaning bright white. The nodule's mildly hypoechoic. You got intermediate echogenicity of the normal surrounding thyroid parenchyma. You're sort of gassed out here inside the trachea, so you can't see through air. Sound doesn't travel through air well. So here's the nodule, here's the thyroid, here's the trachea. Here's the carotid artery. You don't want to go in the carotid artery, you don't want to poke into the trachea. So you got to know what your things are around you. You always want to identify the carotid before you go in, and usually there'll be a big jugular vein around here as well, and try to avoid those. Okay, I've never ended up in them, but you got to be careful. Okay, and like I said too, you don't want to end up in the trachea either, because then the air will start leaking out and it'll mess up your field. You'll have to stop the biopsy. It's never happened to me, but I'm aware that it can happen. Here's a good example of standard technique coming in from a long axis approach. Long axis meaning the needle is orientated along the long axis of the transducer. This would be a real standard approach for a thyroid guided biopsy. Okay, this right here is a different technique. This is called like a PICC line technique, whereby the needle is orientated perpendicular to the transducer. And this technique can be useful, especially when you're dealing with a difficult to reach lesion. You got a big carotid blocking you on one side, some other obstacle like a big trachea blocking you on the other side. So you'll have to take this approach. And when you have to take this approach, you got to be careful because you don't see as much of your needle at a time. So it's a little technically more difficult, but sometimes you need to do it I also forgot to make some points here about coming from a lateral approach. Basically you're like a tiger in the grass, kind of sneaking up on the nodule, then you pounce, okay? So I like it when the near field, meaning the subcutaneous tissue and the muscle, are relatively hypoechoic, because then the needle stands out in contrast. If they're not, and sometimes they're not, sometimes they don't have much muscle, sometimes they got a lot of hyperechoic fat. A lot of patients are short with a big fat neck, or they've had previous surgery, a lot of scar tissue, and it can be tough to see the needle. If the surrounding background tissue is hyperechoic and so is the needle, then it's like a polar bear in a snowstorm. It's very hard to see that needle. You move the needle back and forth, so like a woodpecker, if you will, and you try to catch its view on the ultrasound. And then the real question for me is when I'm coming in towards that nodule, is I have to know from the tech. It helps a lot if I have an experienced tech. Am I above the nodule, centered on the nodule, or below the nodule? Because then I can readjust to get into it. And I always tease the techs. I say, always start by, when you're looking for my needle, always start by in the center of the nodule, which is a joke to imply that I'm always in the right spot. But it's usually true. But what I'm also saying is I have to know that. Am I above or below the nodule? So I can micro adjust to get into it, okay? All right, now here's things that make the case tough. If the patient's, on a ventilator, it's tough to get around them. If I have to do it portable in the intensive care unit, it makes it tough. There's not that many emergency thyroid biopsies, but sometimes it's relevant if they're trying to determine if the patient has metastatic disease, or they got metastatic disease unknown primary, or some of these other unusual situations I get myself into, because then it's a little tough working around this trachea, and you don't want the prep dripping down into their tracheal stoma, or they'll start coughing like crazy. You don't want the contact to be saline dripping down in their trach stoma, they'll cough like crazy, in which case I might use a gel instead. Gel is more controllable, of course, but again, path don't like it because it gets in their specimen. These are the kind of things I run into. The patient's short of breath, and they got to have their head up, some of them. Then if I put saline on here, it's just going to run off the neck. Again, I might use gel in that situation. COPDers on oxygen, they also can't put their head flat. CHFers, congestive heart failure patients, they can't put their head flat. So again, I might use gel, have their head up, okay, during the biopsy. But it's just technically one extra factor to be aware of. Here's a common situation I find myself in. I'll have to biopsy thyroid nodule. It'll be a small nodule. It'll be the size of the common carotid artery, like a centimeter in diameter. And I'll have to be very careful, very good needle control, that when I excurge, meaning go back and forth through that I don't go into the carotid artery. I never have, but I have to be very careful to do it. Again, if the nodule is real small down here, sometimes the carotid is blocking approach from one side, trachea is blocking approach from the other side. And I got to go very slow and be gentle to get in there. But at the same time, I'm going with that stylet needle. I got to be fast. Okay, so these are some of the nuance of it. So you got to have really good hand skills and needle control to not end up in the carotid, not end up in the trachea, and to get into it quickly. Okay, so that's sort of the typical challenge. Sometimes I'm close to the lung with these nodules. They're exophytic, posterior, caudal, at the bottom lower tip of the thyroid. I got to be careful, don't go into the lung. Those are typical things to watch out for. Okay. Oops, that's basically it. I hope you found that helpful.